Happy Monday morning to everyone and welcome. Hope everyone is dry and safe from a tropical storm Hillary that's going on in our area. This is the August 21st SURG Response Subcommittee meeting, and I will call it to order and request a roll call.
Christine Payson. Just Lavada, I'm going to mute you real quick, but you can unmute when it's your presentation time. Christine Payson.
Present. You guys hear me okay?
Yes.
Okay.
Dr. Stephanie Woodard. Dr. Terry Kearns.
Present.
Shayla Holmes.
Present.
Gina Flores O'Toole.
Present.
Thank you. Chair, we have a quorum.
Great, thank you. Thank you to all the members for being here today. We'll go on to agenda item number 2 on our agenda for today, which is public comment. Crystal, can you address?
Yes. So public comment will be received by Zoom via by raising your hand or unmuting yourself when you're asked for public comment. So Chair Kearns will call on you. It's limited to 3 minutes per person. This period is devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241.020. If you're dialing in from the phone, dial 669-449-9171. When prompted, enter the following meeting ID, 868-3331-1069, and please press *9 so the host can prompt you to unmute. You're muted, Terry.
I'm so sorry. I was just going to make a clarification on the slide. It says dial 669-444-9171. You had said 669-449.
Oh, I'm sorry.
That's okay.
Thank you.
I don't see any hands raised for public comment. Do you?
I don't.
Okay, we'll give it just a couple more seconds in case someone's trying to unmute themselves. Okay, at this point, we'll go on to agenda item number 3, which is the review and approve minutes from our May 22nd, 2023 Response Subcommittee meeting. If there's any comments or any corrections anyone would like to make. Hearing none, I would entertain a motion to approve the May 22nd, 2023 Response Subcommittee meeting minutes.
This is Shayla Holmes. I'll make the motion to approve the May 22nd, 2023 meeting minutes.
Christine Payson, I'll second.
Great, thank you. We have Shayla Holmes making a motion and Christine Payson seconding that motion. So the May 22nd, 2023 meeting minutes are approved. We'll move on to agenda item number 4, which is a presentation on emergency department peer support programs by Lavetta Palm. Thank you, Ms. Palm, for being here. I'll turn the presentation over to you.
Good morning, everyone, and thank you, SURG Committee, for inviting me to present our emergency room program that we have currently at University Medical Center. Can you all hear me okay?
Yes, we can.
Okay, so the purpose of the peers embedded in UMC Hospital is to help individuals when they are coming into the emergency room with a opioid or alcohol related illness to get into some form of recovery. And that's going to look different for each individual because there are many pathways into recovery. So some of the people who come into the emergency department and are helped by our peers, they will actually get into detox and possibly longer term treatment. And for those who aren't ready, we can also provide them with resources for programs who accept medication assisted treatment. And also we'll give them referrals and resources for like support groups, or if there's other barriers from stopping them to becoming a better version of themselves, then we try to provide that resource as well. We begin in UMC's emergency room department on March of 2022. We actually went live. Prior to that, we were just basically on call. So we would go in when someone in one of the nurses or the doctors in the emergency room would call and say that they have a patient that we needed to see. So last month was actually, so the month of July was our greatest number of individuals that we saw since the program has been unrolled. So we work currently 7 days a week from 7 a.m. until 5:30 p.m. And after 5:30 p.m., we're on call. And as you can see, we serve a diverse populations. We serve veterans, we serve elderly persons, youth, pregnant, postpartum, women, the LGBTQ plus IA community, people who inject drugs, and other populations who have been disappropriately impacted by the substance use or alcohol use disorder, or in some cases, stimulants. We get a lot of individuals that struggle with stimulant use disorder that also require our support. And like I said, last month was actually the highest number of individuals that we saw. Last month, we saw a total number of, we had 67 referrals. We were able to successfully get 52 of the 67 referrals into treatment. We also end up doing follow-up calls. So what we do is the individuals that we have seen over the course of the previous months, we'll call them. We'll call them at 30 days, 60 days, 90 days, 6 months, and we also reach out to them at 12 months. And this allows us to continue to help those individuals who may have had a reoccurrence of use or who just wasn't ready at the time when we saw them in the emergency department. And I am, as I didn't introduce myself, I'm the project manager here at Track B Exchange, and I'm also the program manager over the embedded peer recovery support program inside of UMC's emergency department. And we also have another peer-based model in the emergency room in Renown's hospital. However, I do not manage that program. Another one of my coworkers manages that program, but it's similar to what we do here in UMC. Individuals come into the emergency room with a stimulant, opioid, or alcohol-related illness, and one of the team members up there will get them into some form of treatment. And that is all that I have to present on the emergency room program. Does anyone have any questions?
Ms. Palm, thank you so much for your presentation. I know I have a couple of questions, but I'll defer to my fellow committee members to see if anyone else has questions first. I'm not seeing or hearing any. So my first question to you is, for your peer recovery support services in the emergency department setting, Are peers being reimbursed for these services?
So so we actually are funded under a grant. So peers are paid for being in the program. I mean, seeing other peers in the program.
So it's currently grant funded, but not through any Medicaid funding?
No, we don't receive any sort of Medicaid reimbursement at the moment.
Okay, thank you. And then my other question, I know you said that this program is at UMC here in the Vegas area and Renowned up in Washoe. So is there a plan to expand this program to other facilities throughout the state? Do you know?
As you know, funding is always a challenge with these programs. So if we're able to locate the funding to be able to provide these supports in other hospitals, we would totally be open to that.
And then I'm so sorry, I have one last question.
That's okay.
But my last question for you is in terms of kind of guiding people into getting into treatment, are you seeing long wait times or are you able to get people pretty much into a treatment facility if they're willing to go?
There is what I consider a long wait time, because it could be anywhere from a 30-minute wait up until an hour and a half wait. And that's when we're dealing with insurances, because even though the peer, we may feel that the person would benefit from treatment and they may feel that they're going to benefit from treatment. But when it comes to the insurance aspect of it, after we do our screening of the client, then the insurance, the facilities, they have to do their screening to see if the client meets their criteria and if their insurance is actually going to pay for their treatment.
And then after all that's done, are there typically beds open to get the person into a facility?
Yes, we have a pretty high success rate. Occasionally, there's maybe one or two people that we're not able to get into treatment when we're trying, but then we'll reach back out to them. We'll make sure that they have a safe place where they're able to go while we still continue working on facilitating their treatment journey.
Okay, and I'll offer up if anyone had another question. Do you know, is open beds being used to find the beds and matching insurance out of UMC and Renown, or are you not familiar with that?
Yes, I am familiar with open beds. And my team has used open beds before, but normally we use our resource the connections that we've already made within the community, our partnerships, places that we know, like I've already done the research and I know what particular insurance this organization is going to accept. And we find out if the patient has been to this facility before and if they, what their experience is like. So we also try to make sure that the client is going to be okay with the facility that we are trying to refer them to.
Ms. Palm, thank you so much for entertaining all my questions, and we appreciate you providing this presentation to our committee.
My pleasure.
Thank you. We can move on to agenda item number 5 now, which is a presentation from the Board of Pharmacy by Darla Zarley.
Good morning.
Good morning.
Chair Kern and committee members. I am Darla Zarley with the Grant and Project Analyst for the Nevada State Board of Pharmacy. And today I just will be providing some of the current laws, an overview relating to substance use disorder. So the first one I'm going to go over is the Senate Bill 459, which was passed in the 2015 legislative session. It became effective October 1st, 2015. And this is the Good Samaritan Drug Overdose Act. This is the act that allowed naloxone administration in an opioid overdose. And Some of the parts of this act that included, it prevents punitive actions against healthcare professionals and any person who administers naloxone or calls 911 to assist someone who may be overdosing on an opioid, and provides immunity to persons seeking medical treatment for an opioid overdose for themselves, and allows greater access to naloxone, an opioid overdose reversal drug. Naloxone is available at area pharmacies and can be obtained now without a prescription, which is great. And there is a over-the-counter product coming soon. It is not available yet, but it was just approved in March of 2023. And I did look the cost. It was hard to find. They're saying approximately $50 for 2 units. But again, it's not something that is set in stone at this point. And I did look again this morning, and it is currently not available yet. If a healthcare provider in a hospital setting would like to distribute naloxone, and I know this was a question that came up previously, they can do it. They can either write a prescription to that patient, or they can have a standing order to be able to distribute naloxone to patients from the hospital. Next slide, please. The next one is dispensing of buprenorphine from a hospital setting. So this became effective December of 2022. And this is a regulation authorizing a practitioner to dispense a controlled substance such as buprenorphine for the treatment of opioid use disorder without dispensing registration. So normally when a practitioner dispenses a medication from their office, they are required to obtain a dispensing license from the Board of Pharmacy. In this instance, they are not required to obtain that dispensing registration from us. And it is restricted only to hospitals or independent centers for emergency medical care. They must have an active Nevada controlled substance registration issued by the Board of Pharmacy. They also need to have a Nevada specific DEA number, and then they have to comply with the labeling and record keeping requirements. And they need to report those dispensations to the Nevada Prescription Monitoring Program. Next slide, please. And in the 2023 legislative session, they passed Assembly Bill 156. And this bill allows a pharmacist to assess the patient to determine whether the patient has an opioid use disorder and whether medication-assisted treatment, so MAT, would be appropriate for the patient. And they, at that point, if they make an assessment where the patient would require treatment or is a candidate for treatment, they would prescribe and dispense a drug for medication-assisted treatment. They provide counseling and information to the patient on opioid use disorder treatment and options, including MAT. The board still needs to adopt regulations regarding this, but those will be forthcoming. They're not completed yet. Next slide, please. And the last one is removal of the data waiver requirement for opioid use disorder prescriptions. So in December of 2022, Congress signed into law the Consolidated Appropriations Act of 2023, which eliminated the data waiver program. And if you're not familiar with the data waiver permits qualified physicians to prescribe buprenorphine in settings other than an opioid treatment program, which was not the case before the data waiver. There were extra training requirements that were required with the data waiver. And in the beginning, they were only allowed to have 30 patients at one time. This act removes the federal requirement for practitioners to obtain this data waiver to prescribe medications such as buprenorphine for opioid use disorder. In January 12th, the DEA and SAMHSA announced immediate elimination of the X waiver for prescribing buprenorphine. The elimination of the data waiver will increase the number of practitioners eligible to prescribe buprenorphine, thereby increasing access to buprenorphine for those patients in need. Next slide, please. The one thing that practitioners need to be aware of, the data waiver registration is no longer required to treat patients for buprenorphine. All prescriptions for buprenorphine only required a standard DEA registration number. So they used to have 2. So they had the regular DEA number, and then they had the X waiver DEA number, which is no longer needed. There are no longer limits to the number of patient caps. So they've eliminated that, which is great. They are requiring a 1 8-hour training that became effective June 21st, 2023. And when a practitioner renews their DEA registration, they have to make sure they have their training done before they renew. And this act does not impact state laws or regulations that may be applicable to prescribing controlled substances. So all of those still remain as they were. And here are some references for you. And that's all I had. Thank you.
Darla, thank you for that update. We appreciate it. Again, I have a couple of questions, but I'll open up to the fellow committee members to see if anyone else has questions. Seeing none, my first question is on SB 459, the Good Sam law. When that was passed, was there an education component done statewide to discuss the Good Samaritan law?
Actually, I don't know. I was not with the board at that time. I know that, are you talking about just educating the practitioners and healthcare providers that this is available?
And the public?
I'm not sure. I'm not aware of any.
Okay, thank you. And then my other question is, has the Board of Pharmacy received any feedback on the Good Sam law? And the reason I ask this question is through various testimony and comments to the SURG, we've heard that many members of the public are still afraid to call, even though they've witnessed an overdose out of fear of being arrested.
We have not received any feedback about that. Not that I am aware of.
Okay, thank you. And then my last question is on the data waiver. Since that has been changed, have we seen a change among the practitioners in our state? Are we getting more more practitioners who are prescribing? And is that being followed through the PMP?
So in the last several years, we have seen an uptick in the number of prescriptions for buprenorphine. I haven't specifically looked at it since the X waiver was eliminated, since it's just been recently. But I can look into that and let you know. I know we've had an uptick in buprenorphine prescribing over the last several years in general.
Great, thank you. I appreciate that. I know that that's been something that we've talked about in the subcommittee, is trying to get more practitioners that are prescribing buprenorphine. So that was the reason for my question.
Part of the challenge with that is getting the prescriptions filled also at the pharmacy level. That's also a challenge for patients who are being prescribed buprenorphine.
What's the limitations there?
Availability.
Oh, so it's not available in all pharmacies? Is that what you're saying?
No, most pharmacies have it, but they don't necessarily have enough of it.
And is there anything that the subcommittee could recommend to improve that?
I'm not sure at this point. I know a lot of that. I'm not sure what the DEA sets for manufacturing of buprenorphine. I don't think they've limited that one. So I'm not really sure at this point.
And you may not know this off the top of your head. I'm sorry for all my questions, but is this primarily in our rural counties, or is this in anywhere, even in our urban counties throughout the state?
It's everywhere, the entire
Everywhere.
state. Yeah.
Okay. I would open it up if there's any questions again from the committee members. Seeing none, again, thank you so much, Darla. We really appreciate you providing this information to the subcommittee.
You're welcome.
And we can move on now to agenda item number 6, which is wastewater surveillance of illicit drugs in Southern Nevada. And I would turn it over to Daniel Garrity. Thank you.
Thank you. And thank you for the opportunity to present the work that we've been doing on this topic along with myself. I'm Principal Research Microbiologist at the Southern Nevada Water Authority, and I've been working with Dr. Ed O at UNLV on wastewater surveillance. Next slide, please. So the sampling for this project was part of a CDC grant that Dr. Ed O was able to acquire working with the Southern Nevada Health District. And so through that sampling, we're able to leverage that in order to look at the high-risk substances that I'll be talking about today. Next slide. So what I want to talk about is wastewater-based surveillance or wastewater-based epidemiology. And if you click one more time. This is looking at chemicals or biological agents. So over the last few years, the focus has been on SARS-CoV-2 as a biological agent, but what I'll be talking about today is the chemical side. And so by looking at these targets in wastewater or sewage, it gives us an opportunity to look at the activities, behavior, or with SARS-CoV-2 and COVID-19, the level of infection and disease over time and space. So different sewer sheds, different jurisdictions within a particular geographic area, that wastewater gives us an unbiased view of what's happening in that particular location. Next slide. So you can click 3 more times just to put them all up there. So based on the type of sampling that we do with wastewater surveillance, it gives us a different resolution for the area that we're looking at. So in public health, one of the most common ways of getting an idea of what's happening in the community is looking at clinical surveillance data. So looking at a clinical swab, that gives us an opportunity to diagnose an individual person, provide treatment for that person, but there's a lot of costs, and in order to get a reflection of the overall community, there's a lot of testing that has to be done. With wastewater, we can collect one sample and get a good representation of the overall community in that one sample at a lower cost. So we can look at samples collected from a sewer manhole, which can be building level, facility level data. We can look at what's called a sewer lift station, and that's going to give us an idea of what's happening in a particular neighborhood or a particular part of town. Or we can look at a wastewater treatment plant and get an overall reflection of what's happening in what I'm calling an overall sewer shed. And I'll go into that map a little bit later, but by looking at the wastewater treatment plant in City of Las Vegas versus Clark County versus Henderson, it gives us an idea of what's happening in those larger communities. Next slide. And click 3 more times, put them all up there. So what this requires us to, or requires the community to do is basically just their normal behavior. So using toilets, washing your hands, taking showers. Once that wastewater goes into the system and we collect that sample, we can look at a whole suite of targets. And I'm just providing an example here of what's been focused on with current wastewater surveillance programs throughout the country and throughout the world. A lot of the targets recently have been on the microbial side, again, SARS-CoV-2 being the most common one in these programs. But again, I'll be showing data on the high-risk substances, illicit drugs, some of the data that we've been generating over the past year in tandem with the COVID-19 surveillance work that we've been doing. Next slide. So wastewater surveillance, the benefit of it is that, like I mentioned, it requires no action on the part of the community. People go about their normal activities throughout the day. We collect a sample, and it's basically a passive way of figuring out what's happening in that community. And so on top of that, it allows us to get a real true incidence prevalence of public health threats based on the targets that we're looking at. And click one more time. And so the most valuable targets, particularly as we've witnessed with SARS-CoV-2, are things with waning urgency. So people are seeking testing less often for SARS-CoV-2. And so this allows us to fill a data gap that can no longer be generated with the traditional public health surveillance that we had, particularly at the beginning of the pandemic when so many people were seeking testing. Another example is something that might have stigmatization associated with it, with the Mpox virus, or in the case of this topic, legal implications or high-risk substances. So with those particular high-risk substances, how do we know the true level of substance abuse that's happening in a community? We can't necessarily get that information by waiting for people to go get testing, because we're going to have a large data gap, a blind spot because of that. But by looking at wastewater, we can fill that data gap and get a better idea of what's actually happening in the community. Next slide. So in terms of special populations, the Southern Nevada team, myself, Dr. Ed O, SNHD, the samples, the locations that we've looked at so far have allowed us to look at these particular populations. So persons experiencing homelessness, elementary schools, and the LGBTQ community. And again, with homelessness, we looked at shelters. So we collected samples from shelters. Ed did some sampling of elementary schools. And then by looking at a cluster of bars around UNLV campus, it allowed us to look at the LGBT community, particularly when the Mpox outbreak was occurring. And then we've expanded that to look at high-risk substances. And I'll show some data later on. So populations that could be addressed in Southern Nevada or have been in other wastewater surveillance programs are veterans, elderly persons, and youths. So again, based on where we collect these samples, it would allow us to look at these particular subpopulations. And then in a lot of examples throughout the country, there's been work that's been done at prisons to look at people who are incarcerated and get an idea of, for example, the level of COVID-19 in that population. So I'm going to show a few slides here showing the data that we've generated just as an example. So we've looked at 39 different compounds, not all high-risk substances, some just indicators of human activity, so artificial sweeteners, for example. But a large portion of that list has been high-risk substances. So again, this is the map showing the way that we can delineate what's happening in Southern Nevada based on the wastewater treatment plants where we are collecting samples. And if you click one more time, we can look at some of the data that we've collected for norfentanyl, which is the major metabolite of fentanyl. And so what you see along the bottom are the sewer sheds that are designated in the map on the left. And then the actual data is showing what are the concentrations of norfentanyl that we're seeing in these different sewer sheds. So more concentrate or a higher concentration would be an indication that there's more fentanyl use in that particular sewer shed. And so we can compare one area to another. So for example, sewer shed 1 being the Clark County unincorporated area versus sewer shed 2, which is Anthem and Seven Hills. This gives us an indication that there's less fentanyl use in Anthem and Seven Hills, for example, but it's not zero, obviously. And so we can get an idea of that spatial difference in terms of the consumption of various compounds. The other thing that we can see with this figure here are the dots above the graphs. So those dots represent outliers or potential spikes in fentanyl use in those communities. So even in sewer shed 2, Anthem Seven Hills, where we don't see fentanyl use that commonly, we still see evidence of fentanyl use on specific dates. And so if you go to the next slide, we can actually look at when these samples were collected. So this is going back to May 2022 up until April, May of 2023. So we did it for a year every 2 weeks. The most notable feature of this data here is that before October 2022, which is delineated by that dashed line, we saw fentanyl use using that norfentanyl concentration was very infrequent in terms of the sensitivity of the method that we were using. After October 2022, we saw it in just about every sample. So there was some kind of change that happened in October 2022, which made fentanyl consumption a lot more common in the communities that we were surveilling with the wastewater that was being collected. And so those red circles for each of those spikes that you see are the actual dates that are associated with the dots that we saw on the previous slide. So the spikes in norfentanyl concentration representing fentanyl use were occurring on those particular dates. Next slide. And so, like I mentioned, without this type of data, it's difficult to figure out what the overall consumption is of these various compounds. So I'm providing, again, an example of the compounds that we've looked at, the overall consumption estimate for each one of the sewer sheds, and then the total for Southern Nevada. And so when we have seizure data, for example, or if we have overdose data, that gives us a piece of the information. But by looking at wastewater, it's essentially giving us the overall consumption that's happening, and we can compare in terms of the efficacy of law enforcement measures that are going on in terms of seizing these compounds and trying to get them off the streets. So how effective are we, and how is that changing over time? This wastewater data would give us a reflection of what's occurring in that sense. Next slide. And then the last thing I want to talk about is facility level sampling. And so the previous slides, I was showing data for samples that were collected at a wastewater treatment plant. And so that's shown here, the WWTP are the concentrations of each of these compounds collected at the wastewater treatment plant. And then the columns towards the right represent more localized sampling locations. So this is where we're going into manholes, collecting samples that allows us to get more higher resolution data, potentially more actionable data. So the one that I want to focus on here is the bars. And you can see that the concentrations for the various compounds that are listed here are pretty high at the bar location relative to the other locations. Notably, norfentanyl concentrations are higher, but more importantly, we're detecting that norfentanyl in these manhole samples that are representing these bars. So what that means is that there's fentanyl consumption that's causing norfentanyl to be released by these people who are at these bars. And that's potentially because they might be taking high-risk substances that are laced with fentanyl. And so they might not know about that unless you have this type of data. And so by having this detection of norfentanyl at this manhole, it could potentially provide public health an opportunity to go in, increase awareness about the potential lacing of drugs with fentanyl to prevent overdoses. So that's one example with the bars. If we move over to the hospital, throughout the entire sampling period of this study, we only detected one sample with xylazine. And so that was the hospital manhole where we collected that sample. And so in this sense, it gives us an indication that wastewater surveillance is also sensitive enough to find xylazine and detect its use in particular parts of a sewer shed. And then lastly, on the far right, Flamingo Wash, we've used this particular sampling location as a surrogate for unsheltered homelessness. So again, by seeing that norfentanyl in the water that's collected from that wash, it's an indication that fentanyl is being consumed within the unsheltered homeless community that's living upstream of that sampling location. Next slide. So in terms of gaps, we've collected a lot of wastewater surveillance data. We've figured out what the concentrations of these compounds are. What we now need to do is work with public health, look at the data sets that are available to see how well this wastewater data is correlating with what public health is seeing in terms of the more traditional clinical surveillance data. Next slide. And then recommendations. What we need to know on the analytical side, on the study design side, or what are the gaps that public health currently has that can potentially be filled by wastewater surveillance? What are the substances of greatest interest? Which compounds should we be looking for in the wastewater? And how can we present and communicate these data to maximize benefits? Next slide. And then lastly, you can click 2 more times to put them all up there. So recommendations are to reach out to groups who have already implemented wastewater surveillance for high-risk substances. So on the final slide, I have a list of references that can be looked at to see what other public health groups and wastewater surveillance groups are currently doing this for high-risk substances throughout the country. We need to assess whether wastewater surveillance can fill critical data gaps and or improve response and intervention efforts. So I provided a few examples here. There's probably a lot of other examples that public health professionals will have on how this data could be used. And then lastly, engage with public health departments and other stakeholders to develop a program that best fits the needs of the local community. So we're looking at what can be done. We need to know what needs to be done to help public health people address these knowledge gaps. So by having these communications, we can better develop these programs to answer those questions. And last slide. So these are the references. And one more slide. And then this is our contact information. So myself and Dr. Ed O, who I think is also on the call and can answer questions.
Thank you so much for that presentation. It's very interesting. Again, I'll open it up to my fellow committee members to see if anyone has any questions.
Dr. Kearns, this is Shayla Holmes. I have a question.
Please go ahead.
Thank you so much for your presentation. When we were having conversations like this during the COVID pandemic up here in the north, I know there was some concerns regarding like manpower and how they're able to do that. So when you talk about like actually going out to manholes, that's somebody from Southern Nevada Water Authority going out every 2 weeks and doing that. Is that like outside of your guys's normal work? Are you guys in those manholes anyway? Like how much of an additional burden is this to you?
Yeah, great question. So for us personally, it's definitely outside so the whole wastewater program has been outside what we normally do. So I'm coming from a drinking water utility, but we had the capability to do a lot of this work where a lot of labs, for example, were shut down early on in the pandemic. We had the opportunity to do that. And so we started looking at it from a research capacity. Over time, it's expanded to once we realize, hey, there's a great benefit to public health here, we've been trying to show basically a proof of concept that this works and it provides really valuable data. And so if we can demonstrate that, our hope is that public health programs will adopt this, use public health resources to expand these programs to best fit their needs, and then work closely with the wastewater utilities. So the wastewater utilities have a lot of personnel who go out to a lot of these locations to service the manholes, not necessarily to collect samples normally, but if there was a need for it and we could demonstrate the value of it for public health, these wastewater utilities have been very receptive to taking on some of that role to try to help public health answer these questions. So whether it's the wastewater utilities or public health people, again, if the funding is available, the resources are available, those samples could be collected to try to answer these questions. So it's a matter of finding the right people to expand these programs and make them valuable to public health.
Do you know by any chance on the wastewater side? I know you said you're a drinking water side. I know that at least here in rural Nevada, a lot of ours are combined. Do you know the frequency that the wastewater folks are needing to go into these places? Do you have any idea on that, or is that more of a probably need to do some local digging kind of question?
Yeah, it'll probably be pretty system specific on how often they go out. It's not going to be common to go out to a bunch of different manholes unless there's problems. So if things are backing up, they're going to go out and have to do service because there might be a blockage or something like that. But normally they're not going to go out to a bunch of different manholes throughout the day. But working with public health people, you wouldn't necessarily have to go to a whole bunch of manholes. You could identify strategic locations that represent high-risk communities. And so maybe it's just a few manholes every 2 weeks, for example. It makes it more manageable by finding those strategic locations as opposed to just trying to get information about the entire sewer shed. But going back to the question of rural versus urban, rural communities are going to be a lot more resource restricted. So their primary responsibility is to make sure these wastewater treatment systems are operating the way that they're supposed to. That might be a greater it might be a greater burden on them to adopt something like this because it's more outside of what they typically do. And so it's just, you're going to have to look at system by system, which ones can actually implement something like this and which ones maybe it's not going to work because they just don't have the resources.
Gotcha. Thank you so much. But you do think with an appropriate level of funding, it is something that could be supported in either the wastewater system or in the public health system, or some sort of partnership between the two?
Yeah, definitely. I think with the resources, and I think just leadership. So finding somebody who can kind of lead the overall program and be the point of contact to make sure that all this information is getting to the right people. That's been one of the struggles for me, not coming from a public health background, learning the hierarchy, the organizational structure of public health, trying to figure out who needs to get this information to make it actionable. If we have the people in the right place that know how to make all those connections happen, without a doubt, this is going to be a valuable addition to what public health surveillance tools are out there already.
Fabulous. Thank you so much.
Any other committee members have questions? I had a couple. I know on the one slide you talked about, I saw a bullet point of about the high-risk substances, and I wonder, this doesn't really delineate whether they're illicit or licit substances. Is that correct?
Yeah, so once I was invited to this, the high-risk substance is the better term to use because, yeah, like you said, they're not, like fentanyl isn't necessarily an illicit substance. It has uses in hospital settings, for example. And so, yes, not all the compounds are specifically illicit versus licit.
And then my other question, I know you gave references of other places that are utilizing the wastewater. Are there any other places that you're aware that are utilizing this data for public health purposes?
Yeah, so the Marin County, if you go back one slide, there at the top, there's more public health examples that I provided. So Marin County in California is the one that detected xylazine in their wastewater as well. And so they have examples of public health actions that they've done based on the wastewater surveillance data that they've collected. I will say that the high-risk substance application of wastewater surveillance is not as frequently used. I'd say it's definitely growing, but there's very few communities right now that are using this. But there are, I think, 500 plus systems throughout the country who are using wastewater surveillance for SARS-CoV-2. So the infrastructure is in place. It's just a matter of taking those same samples and analyzing them for the compounds of interest to those communities. And so there's an opportunity to expand the existing programs to answer a greater number of questions.
Thank you. That's all the questions I had. Any other questions from committee members?
I guess it's just a point of like, 'cause you mentioned it. So to that point, as far as illicit versus licit substances, we don't really have a way of identifying that. But if you do this consistently and regularly in strategic places, then you can kind of identify a baseline and then see if there's influxes, so to speak, or oddities of where we didn't typically see this substance or this compound here before. Now we see it, or we used to see it at this level, like you showed on that one graph, and then you're able to see, spikes over different periods of time. And you guys were doing it every 2 weeks, so I guess that's like the point that you had mentioned just a couple seconds ago about, being smart with their time or resources and funding. What's the accuracy and the time there? So, I mean, of course, depending on how frequently you go out. So say you go out every 2 weeks, is that a reflection of the last 72 hours? Is that a reflection of the last 2 weeks? Like, what is the time frame of which that those compounds being identified? How long are they like active, or am I making any sense in your language?
Yeah, so when we go out and collect a sample, it's basically telling us what's happening right then. So
Okay.
same thing with COVID, especially when there were lags in testing and reporting. We can get that wastewater data. If it's very time sensitive, that wastewater data can be generated in a day or maybe 2 days, whereas some of these other targets in the traditional public health surveillance might take up to a week, for example, or maybe even more. So the sample that we're collecting is people are flushing their toilets, they're taking showers. That sample reflects that particular point in time. Related to the kind of the first part of your question, the part that I don't have yet is the public health data for prescriptions, for example. So when we see oxycodone and it's much higher in a particular area versus another, that might be explained by just more prescriptions for oxycodone in that particular area. So by connecting those two data sets, we'll know, okay, yeah, we expect that sewer shed to be higher because there's more prescription use in that particular sewer shed. Or on the flip side, maybe there aren't prescriptions and we see a bunch of that. That's an indication there's a disconnect there. There's something that needs to be investigated to better understand what's causing that. So that goes back to connecting the right people who have the data sets that can answer those questions. But then to answer your other part, it's right then, that particular point in time is the sample that we're collecting, and that's what it's reflecting, that point in time.
Fascinating. Okay, thank you so much.
Yep.
And you had mentioned about working with law enforcement for seizures or public health. I would be curious, we do have a database with suspected overdoses. It would be interesting to go historically and compare that data with what you guys have.
Yeah, I would love to dive into that data. I've presented this to the health district in the past, and one interesting question that somebody raised is that if you have overdoses, those people aren't going to be excreting these substances to the sewer. And so there's potential for a disconnect there. If you have a lot of overdoses, you might not actually see it in the wastewater system. But if you do see it in the wastewater system, it might be predicting overdoses that you're going to see just because there's more use in that particular community. So those are the types of questions that we have to figure out how to answer to know how well these data sets correlate. And if there is a difference in what we expect, is there an answer for that? So those are the types of interpretations that we'll be working on.
That's great. All good points. Thank you for taking a very complex scientific thought and kind of putting it into a format that we can all understand.
No problem. Happy to answer any questions that come up, and thank you again for giving us the opportunity to present.
Thank you. If there's no other questions from the committee, we'll move on to item number 7 on our agenda, the crosswalk of the Good Samaritan and drug-induced homicide laws with Teresa and Elisa.
Hi, and I'm just gonna give an introduction for Alyssa real quick. I'm Teresa Benitez Thompson, and I'm Chief of Staff to Attorney General Ford. And we, per the last SURG meeting, there was a recommendations under review that talked about conflicts between Good Samaritan law and drug-induced homicide law. And so with Alyssa Engler, Terry and I kind of reviewed the 2 other laws that were out there, Delaware's law and Rhode Island's law, and how they were similar and or different than Nevada law, and kind of what those looked like. And so Alyssa, who is our Senior Deputy Attorney General here in the office, I'm going to let her take it from there.
All right. Good morning, everybody. Thanks for having me. I am the chief of our prosecution unit. And in conversations with Teresa and Terry regarding, what does Nevada law look like, I kind of wanted to just have like an open discussion and maybe an explanation of kind of my interpretation of Nevada law. So we have our what would be considered our Good Samaritan laws under NRS chapter 453C.150. This is what would be considered immunity for certain offenses. If someone provides medical assistance when someone is facing an overdose. And the statute's pretty clear, and it limits the individuals that actually would qualify for immunity should they call under the Good Samaritan. And I've broken down really the circumstances where somebody would qualify for immunity, and that would be misdemeanor drug paraphernalia offenses, possession not for the purpose of sale. So what essentially that would be possession of any drug amount that would be less than the trafficking levels, and with other evidence would be indicative that it's simply for someone's personal use and it's not for other purpose of sale. So for example, if somebody calls for assistance to somebody and they police arrive and someone might be in possession of some drugs, but then also might have a scale with them. There might be individual baggies around. They might not interpret that as someone who's simply in possession, and so they might not qualify under immunity. And then an individual who's also under the influence would qualify for immunity. A violation of a restraining order, they would qualify for immunity. And then you could not be violated under your parole or probation if you called for assistance. So those are really the limited factors. Under that statute, though, they give prosecutorial discretion and allow a judge to consider mitigation evidence if you are charged with a crime and you did call for assistance. The court can take that factor into consideration when putting in or when sentencing an individual for that. So those are the limited instances where someone is protected under the Good Samaritan laws. I think what the biggest concern that everybody has discussed is how does the drug-induced homicide laws play into the Good Samaritan laws, because the way that statute's written leaves it very broad. And that statute is specifically NRS 453.333. That is our drug-induced homicide law. And what that statute says is if there is evidence that a person supplied a drug that was the proximate cause of a person's death, they could be charged with murder under our murder statutes. When they say supply, that could mean selling, giving somebody a drug, trading them a drug, or otherwise made the drug available to the individual. So that's very broad and pretty much opens anybody up to being charged with this if there's evidence that an individual has supplied a drug to someone who then overdoses and causes the death. I did have an opportunity to speak with the Clark County DA's office regarding how they interpret and how they handle, from a policy perspective, the drug-induced homicide laws in reference to the Good Samaritan laws. And from their office's policy, they focus and would charge the drug-induced homicide only in situations where the person has sold, there's evidence that it was a sale, that the person is out there selling these drugs. They don't, and their policy is not to focus on, you know, friends giving a drug to another friend and then the death results from there. Unfortunately, and we see this all the time when we're trying to create laws in Nevada, there is the prosecutorial discretion, and certain prosecuting agencies are going to treat the laws differently, but we have to look at the overall law and how it's applicable throughout the state. And we do have, I would imagine prosecuting agencies might treat the laws differently in rural counties versus more urban counties. So while the Clark County DA chooses to really kind of focus when they actually charge the drug-induced homicide, other counties might treat it differently. So there isn't really a good answer as far as like how this is titled as a crosswalk and how we would approach it. But I think Clark County DA has taken a more I would say conservative stance as to when they would actually charge it. And they did indicate to me that when they do charge it, they're doing second-degree murder and not first-degree murder as well. Even though the statute does allow for first-degree murder, they're keeping it at a second degree, which does lower the penalty range. So that's what I have in terms of kind of an explanation of the law. I don't know if anyone has questions about the interpretation, and I'm happy to answer any more of that. I know Teresa might have a little bit of input as to where we might want to go in looking at the two other states that she mentioned.
And first, I want to apologize because I introduced you as an SDAG, Alyssa, and you're the chief. And so my apologies. I was, I got that incorrect. And she's wonderful and so important to the office. So I want to make sure I get that right and acknowledge that I misspoke there. But I think the goal was to provide the committee with some background on how our statutes look, and then the recommendations are out there. So I guess we can answer questions if you guys have questions.
I'll open it up to any of the committee members if they have questions first. I don't know if it's a question or a clarification. And I know that when this came up, we had asked if this had been charged frequently. And I think there were only a couple of cases. I don't know, Alyssa, if you know how many cases?
As far as the drug-induced homicide? Yes. Yeah, I think when I spoke with the Clark County DA's office, the deputy that I spoke to took over that unit, I think in the last year or two. He actually testified when we presented our SB 35 before the legislative session, and he talked about how there were cases that were presented to them that they did not charge, specifically when they made kind of their policy decision within the office to focus it solely on charging those who have who actually are suppliers. And by that, there's actual evidence that they are the ones that are out there selling the drugs and supplying them for purposes of sale. So it has been charged in that context. And I know I don't have an exact number, but I do know that it has been charged in Clark County. But again, on that focused area.
And one of the recommendations that we had from the larger surge was to do kind of like an ad campaign outlining the Good Sam law. And my only concern was we do still have some question, and I think through testimony and through comments, public comments to our surge, there are people who still are afraid to call when they've witnessed an overdose out of fear of being arrested. So not that you have a recommendation, but just if you have any thoughts.
Yeah, I mean, when looking at the Good Samaritan law, so just for a couple of instances, in order to get immunity for whatever reason under the Good Samaritan law, you have to do certain things in order to qualify for that. So that could simply be reports a drug or an alcohol overdose to a member of law enforcement or a 911 emergency service, poison control. So you could simply call 911 and that, you know, would qualify you. You could assist somebody else in making a report. You could provide care to a person who's experiencing it, or deliver somebody to like an emergency room. So you could simply drop them off. So there's a wide range of options that individuals can do. So I don't know, from like a public awareness campaign, when we're talking about the Good Samaritan laws, if it's saying, you know, if you do any of these things, you know, you're qualified under Good Samaritan. That might, knowing that if you're able to call or even just drop somebody off and then leave, that you're at least providing aid under that. And that might give people who are in that situation a little more assurance that they don't have to remain with that person throughout the entire situation. I don't know if that's any of assistance. And then from a public awareness standpoint, as far as what qualifies as immunity, you could talk about the instances where somebody would not would qualify for immunity in terms of being in possession of, you know, a gram of some type of drug or an ounce of some type of drug isn't going to cause you to be arrested for that. If you're also under the influence, and that's at the time you call, that's not going to cause you to be arrested. If you happen to have a pipe on you, or the pipe is next to you when you call and they arrive, then you're probably not going to be, or you would not be subject to arrest for that. The other thing I wanted to point out, and I probably didn't mention this before, generally on these overdose calls, I don't even know that law enforcement's actually responding to a scene. If somebody calls 911 and medical personnel is sent out to assist, law enforcement is likely not even responding to that scene until if it unfortunately results in a death, then they might be called out. So I really do think that there's probably more of a fear that's out there, but it's probably more of an unrealistic fear. I think ultimately law enforcement, especially, they want people to be saved more than they want to be arresting people. And when they're focusing on the arrest, they're wanting to do it for those who are the dealers and not just the users.
Thanks, that all makes sense. And if I remember, you or Teresa both looked at the other laws from Rhode Island and Delaware, I believe, and ours was fairly comprehensive compared to those. Is that correct?
Yeah, Teresa, go ahead.
Yeah, especially when I think we were looking at it, the distinction between the simple possession and that being covered by Good Samaritan laws in Nevada, and seeing that language a lot reflected with Delaware and Rhode Island, and kind of being in that same vein. And then within trafficking, less so, there's some of those qualifiers there, but also that you take action matters and is mitigating for you. So we really do want to emphasize people taking action, calling for help.
Shayla, did I see you had a question?
I did. I guess I'm just curious, or I guess I need some additional clarification on the two laws aren't necessarily linked, right? So Good Sam, you have immunity if you meet that criteria population, but if that individual you called for ends up dying, you don't necessarily have immunity to the drug-induced homicide law, depending on whether or not there is a connection to whether you supplied it, sold it, gave it to, did it with. So Good Sam doesn't actually protect you from drug-induced homicide laws.
Yes, that you stated that 100% accurate. I think the key factor is the evidence portion, right? So if friends are using together and somebody happens to overdose for whatever reason, maybe one of the drugs contained fentanyl and they didn't know it contained fentanyl, they would still have to show that their evidence that person, the friend who called for help, is the one that supplied it to the friend that's overdosing. I don't know that there's going to be clear evidence of that in most situations, but for me as a prosecutor, I would want more evidence than just that person being present with another person and them overdosing in order to charge somebody with drug-induced homicide. Once you get, we have a burden, obviously, beyond a reasonable doubt. I would want some clear evidence of the sale to feel comfortable charging somebody with that. But as far as the way it's written, yes, it would not, as the way the law is written, it doesn't protect them if the evidence is there.
Thank you. That's where I was just trying to process the two side by side, and they're not necessarily linked.
Correct.
Do any other committee members have questions? I don't see any. Thank you guys again for taking a complex legal topic and trying to really break it down and make it more understandable for all of us. We appreciate it. At this point, we can move on to agenda item number 8, which is the 2022 response recommendations review and discussion, and Vice Chair Holmes will handle this topic.
Okay, everybody should have received a handout in their email showing the recommendations from 2022. I don't know if you can share that, Crystal. Yep, you've got it. You've got the slide up. Perfect. So the purpose of this agenda item is for us to identify, based off of our recommendations from 2022 and the status of what's happened with them since those recommendations have been made, if we feel there needs to be additional work done on any of them. And if so, we need to get somebody to champion resubmitting those recommendations with the new information, updates, or whatever it is we'd like to see continued on them, which came from this conversation at the Greater SURG, like what happened to these recommendations? Do we just let them die? We've recommended them. Here we are making new recommendations. So I guess we'll give it a minute for everyone. And if anybody has any additional information they'd like to provide regarding any of the recommendations made. And then if we feel there still needs to be more work done, we need to have that conversation as well.
Vice Chair Holmes, would it help if I shared that other document that has the status?
Probably, that would be great. So if we, looking at this one, I guess, I mean, we could go item by item if we need to in regards to the first recommendation was revising the penalties based on the quantity of fentanyl analogs or other synthetic drugs of high potency that are trafficked. So there was some legislative work that happened on this, which is in that SB 35 and AB 137. Do we feel our work is done on adjusting the laws regarding the trafficking weights?
This is Terry. I was just going to add that I know there were some changes that were done with SB 35. And Teresa, if I can lean on you to talk about what those changes were from what was originally recommended for SB 35.
Originally proposed. Yes, so in the original bill as introduced was so trafficking of fentanyl for a trafficking potential trafficking sentence for anything over 4 grams. And through the course of conversation with different stakeholders, quite a few different stakeholder groups, that number by the end was changed. And so now you've got kind of a low, a mid and a high. So the 28 grams, starting at 28 grams. So we moved from what would have been 4 grams, which we heard from the Substance Use Disorder and Recovery community that was too low, that you would capture too many people who had fentanyl on them for personal use versus trafficking. And so reset it up to 28. And then it went, I think it's 28 to 42-ish. And then I've got to pull up my notes here. Hold on. It goes up to 100 grams total. And then after 100 grams, existing statute takes over from there. Also built into there, the very, very strong kind of bordering line requirement for prisons and then jails to be able to set up and establish medication assisted treatment programs. And so certainly want to nudge and push folks who are incarcerated to be able to have that treatment and access to help within their jails and prisons. Some are already doing that. Some are not. Some are thinking about it. So we definitely want to push towards the action of getting that done and implemented, as well as we ensured that Good Samaritan laws, as they were already standing regarding trafficking in 453, carried through with these new changes on the levels for fentanyl trafficking as well. A separate bill, it wasn't ours, but allocated, I think it was about $500,000 so that DPS could purchase lab equipment to move towards quantitative testing over qualitative testing. As well in SB 35, the legislators wanted to add in components to that bill requiring a study to look at a change in our testing at the lab level from qualitative analysis to quantitative analysis. And so they will be doing that from their study level. And we're not so much involved in that. We're gonna, I think, be hearing from the interim committee on the interim legislative committee on judiciary they're going to set that agenda. They're going to kind of set what those parameters look like and what they want their study to look like. I don't know if they've got a pot of money allocated to them or not, or they're just going to use their existing time and staff resources. But we'll certainly be following that. The goal would be a real understanding of how such a change for testing fentanyl from qualitative to quantitative, kind of how that would look for the state and how that would play out across the board if the state went that route.
Thank you so much for that information. You didn't know you were going to get a test today. With that being said, I mean, there was traction made on this goal. I don't remember, and I think is Christine Payson on the call. Was she the one that did that original presentation for us with the her recommendations as far as deaths by grams or weights? I'm not sure if this subcommittee at this point in time feels that we can check mark this and move on, or is there additional work that we would want to see done? Do we feel that the legislation that was passed fit what we would still recommend?
Hi, Christine Payson here, and sorry if you're hearing my dog in the background. I personally take it as a win. I mean, it's not as low as I would have hoped, but at least it does differentiate between the levels of trafficking, low, mid, and high. So personally, I'm good with it.
All right. Well, not hearing anybody. Dr. Kearns, did you have something you wanted to add?
Yeah, my only comment was, I think that we can check it off, but it would be of interest to follow just in terms of the laboratory quantitative testing piece of that. And, because of having the study being done and then the purchase of that equipment and just following that. I noticed on here about Nevada EMS purchasing mass specs. That is not the same thing. It's very different. It's for public health purposes, and with 2 of those going to each of the counties. So that's a separate issue from the lab quantitative testing, but I think it's important to continue to follow that component of it.
So what I'm thinking is maybe this recommendation is done, but now because of this, we have a different recommendation that's more data focused. That is over the next 2 years to continue to review or identify a champion that would review, who should review this data consistently to see if the laws actually reflect the findings. I don't know if anybody wants to own making that recommendation. So the piece that I didn't perhaps make clear is not only do we need somebody to champion these, what we mean by that is you need to go back into the survey and you need to put them in there. So that way they get reflected in this year's recommendations.
This is Terry Kearns. If I remember, I thought there was a recommendation on data collection. So I don't know if this would fall, because I find it interesting. The law enforcement data is going to be very different than the data from the mass specs and even wastewater sampling. So, it might be an overall data collection looking at all of those different components.
So I submitted the wastewater recommendation, and based off the presentation today, I do think that we need to find specific funding for that. I don't know if that could be morphed into one giant recommendation because I also know our law enforcement, and Christine, you might know a little bit more about this, but I know for my local law enforcement, we have to set aside, the funding is not there for them to be able to test everything they confiscate for fentanyl, that is an additional test and it's more costly to test for everything. So they test for what they think it is as a cost saving measure. So I think that there is room to increase funding to all of our jurisdictions, because maybe we're not catching information about fentanyl or other opioids throughout the whole state because other budgets are smaller. So they're just not testing it. And I think all of that is data that could lend itself to being able to make some of these recommendations more, concrete.
Hi, Christine Payson for the record. Correct, we can't test everything that comes in currently. But I was at a conference recently and a doctor presented on a law that was passed in California. I think it's called Terry's Law, but I can find out for future meetings. And it was a way to add fentanyl to a regular tox screen panel. So not necessarily testing the substances that we're seizing, but there's grant money and a template already available for states to get this additional testing done in a tox screen. So I don't know if we could reword it for, to make it a goal to get that Terry's Law on here in Nevada like we did in California, or if that would have to be under a different category.
It almost sounds like we have like two separate recommendations, although all of it leading towards the data collection piece. But to me, it sounds like we have one leaning more towards public health data and one leaning more towards law enforcement data. And is that two separate? Does one require legislation? So Christine, you mentioned you're not currently able to test everything for fentanyl as far as substances. Is that like a law that prevents that from happening, or is that a funding thing? To me, it was just a funding thing, but I don't know.
I believe it's just a funding thing.
Oh, okay. So maybe it is one. I think unless somebody wants to arm wrestle me for it, perhaps I can attempt to edit my recommendation on wastewater data and try to make a more broad data recommendation that touches on these three different pieces. It sounds like a talk screen. That sounds like a person. That's like testing individuals. Am I right there? So testing for individuals being arrested, testing for substances being confiscated, and then utilizing available public health data such as wastewater. So I think I'll try to morph that into some funding for those specific streams and see what we can agree upon.
Dale, I think too on the tox screens, I don't know if this is what Christine saw the presentation on, but it was hospitals too that were doing tox screens on people who came in who had overdosed and adding fentanyl, because fentanyl, they had to send it out, and that ended up being multiple days to get the results back. Whereas if that was added to the tox screen that's done in the hospital, you get more real time within hours results. So I'm not sure if that's the same, but it could also include tox from hospitals.
Sounds
Yeah,
great.
it was the hospital tox screen that I saw the presentation on, and there was actually some hesitation by some physicians to even order the fentanyl test. I think it was for liability reasons, but like I said, I can get at the documents on that law that they recently passed in California and see if that's of any help to you, and get that to you, Shayla, if that's not violating any kind of meeting rules.
No, that would be great. Man, the things my brain just doesn't think about: liability and testing someone at a hospital of all places. Wouldn't you want to know what they're on so you could better treat them? On that note, I don't know if there's a presentation that we could get, or if maybe this is just a lack of my knowledge. But I was having this conversation the other day in regards to how do hospitals identify an overdose? And are we talking, when we talk about overdose and we talk about, I guess just overdose in general, it feels like we're leaning towards like an opioid overdose, right? But we're tasked with identifying substance use issues at large. And I know I've had a lot of local conversations in regards to youth that have had a high amount of THC that is resulted in them having to have a hospital visit. But does that get considered an overdose if they've had so much THC that they're like comatose, but they're not over? I mean, where do these different substances get titled and labeled, and how do we make recommendations that capture all of that? I don't know if anybody has the answer. I'm certainly baffled. I don't know. I don't know if it's just because I don't talk with the hospitals enough. Perhaps I need to go make some ER friends.
Dale, I was just going to say you're absolutely right. Overdoses present in different ways depending on what the substance is used. So a stimulant overdose would look very different than a opiate overdose would look very different than an overdose with THC. So I think those all would fall under that category within an emergency department. But then they have to start doing the rule outs and rule ins based off tox screens and use and those sorts of things.
Thank you so much, Dr. Kearns. That makes a ton of sense, so that their brains aren't just focused on opioids, kind of like my brain gets focused. But I think then, to Christine's point about, and your point about the tox screens for anybody coming in on fentanyl, because when I hear from my local EMS that they are taking kids in that are that aren't responding at all to even like an IV, and that it's THC related, to me, I'm like, man, is that like the laced marijuana of fentanyl that we're hearing? But if they're just coming in presenting with THC, are they even being tested for fentanyl? Do we even know if that's a thing? I think that to me, and maybe I'm like dating myself, to me, that just sounds crazy that somebody could have that much marijuana in their system that they wouldn't even respond to like an IV putting in. But I hear the stuff that you buy these days is way crazier than, you know, whenever I was young. Okay, so it sounds like we're gonna adjust the data piece, and that perhaps recommendation 1 is checked off. So we'll move on to recommendation number 2, which is actually recommendation number 5, to leverage existing programs and funding to develop outreach response and or personnel that can respond to any suspected overdose and offer follow-up support, referrals, and services to the individuals and loved ones following an overdose. Providers and or personnel to be deployed to anyone being released from institutional and community settings, examples like hospitals, other facilities and institutional settings, who's being discharged post-overdose or suspected overdose. Any thoughts on this one? I feel like we're still working on this when we're talking this peer support from EDs, and it looks like the notes on here is that the crisis team is new, part of the Bureau, but I'm not sure we've actually made this happen. So thoughts on this one? Do we still feel it's a priority to make it a recommendation? Do we need to morph it? I think originally this was one of my recommendations that got morphed to fit with another recommendation. So I'm not sure which part of this was, I think, you know, mine was the community setting focus, but I think it did get shifted. I personally think this is still important. And I still think there's a lot of work to be done, particularly in the emergency department piece.
Shayla, Terry Kearns, I was just going to add, I agree. I think this is something we should still follow because this takes in a lot of different things in my mind. And we had the presentation on the bridge programs and the emergency departments, and also providing naloxone in emergency departments without a prescription. And then also the trying to go down the route of seeing if community paramedics can do follow-up as well within peers. So I think we still have some work to do. And it sounds like we have some of this going on in certain places, but not everywhere throughout the state.
I agree. So Crystal, you need somebody to put this back in. We can't just decide right now we want to keep it.
Ideally, someone would put it back in because it sounds like maybe there is a slight revision to it. If you wanted to bring in more, calling out more of the things that we've heard this year, like bridge and other things. If you did want to bring it back in, someone could just email me, we want to bring it back in, and all of the same justification from last year applies. That's kind of what we're looking at, because the reason we're asking for the survey to be completed is because we want consistent information on all of the recommendations, whether that's one from this year or one that we are considering. So if someone doesn't want to go through the hassle of the survey, I can always take that information in an email. I just would want it to hit all of the areas, which you can see it's this information. So describing the recommendation, what sections of the law does it cover? or of AB 374, and then what are the populations? So things like that. We just want all of that information.
Okay. Anybody want to champion recommendation 5 and perhaps adding in the presentation recommendations we've had thus far?
This is Terry. I can try to work on that one and see. And I was also gonna say, we've hit our end time of 10:30. So if committee members can't stay, we can push this out to the committee members.
Thanks for that note on time, Terry. I'm good. Is are folks needing to hop off? Are we about to lose quorum?
I have another meeting to prepare for, sorry.
Okay. So would you guys prefer to push this work via email? As far as like read this and then make recommendations that you feel are important. It can't be like group work. It has to be individual work. And if we end up with duplicates, so I guess that's what we'll do. Please, for recommendations on your guys' handouts, 10 and 17, review those. If you find them to be important, or if it was a recommendations of yours previously and you don't feel the work is done on it, please resubmit it or edit it to be relevant to the current times and resubmit those. I think Crystal can send out the survey again. So that way, though, your recommendations don't die, essentially, right? Because if we don't get them back into this year, we're not going to keep coming back to 2022 and reworking these. So 2023's recommendations will be reviewed in 2024, but we're not going to just keep going back year after year after year. So if these recommendations are critical to you or important to you in your work, please review them, resubmit them. And again, it can't be group work. It's got to be individualized. So we talked about the first two. We'll commit to looking at the second two. And with that, I think we can close out this agenda item.
And just briefly, that would take us to the next agenda item, which is number 9, the response recommendations process. And in looking at the process in the last SURG meeting, we talked about looking at, go ahead, please move to the next slide, of looking at the recommendations to have a more objective component to it. So please look at the recommendations for 2023 and committee members and come prepared to address that impact, capacity and feasibility of implementation, urgency, and how the recommendation advances the racial and health equities. This provides more of the objective part. I think what the decision was is that we would push all of our recommendations forward, providing backup with addressing these 4 components, and then the overall SURG would take those recommendations and would weight them as we did last year. So each committee should have no more than 5 to 10 recommendations, and then relooking at our recommendations from 2022 as well. So at our next meeting, we would need to have an in-depth discussion about the recommendations. So please come prepared to discuss those, because we will have to present those for the October meeting. And then after that, we will have to meet in late October or early November to refine the recommendations based on the discussion at the October SURG meeting. So I think that covers everything, unless I missed something, Crystal. Am I?
That was it. That was good.
Our next meeting is scheduled for September 18th, 2023 at 9 a.m. And then we can move on to agenda item number 10, which is public comment.
Okay, so I'm going to read this again. Is that correct, Terry? I think that's what we need to do. Oh, we don't have to do the number the second time, right?
Correct.
So if someone wants to make public comment, please raise your hand if you're joining by Zoom. If you're only on the phone, you can come off of mute and let Chair Kearns know you would like to make public comment. It is limited to 3 minutes per person. I'm not seeing anyone indicate they'd like to make public comment.
I am not either. At this point, we'll move on to agenda item number 11, which is our adjournment of today's meeting. Thank you to our committee members and also for our presenters and also for members of the public for attending today's meeting.
Thank you for your invite.
Thank you.